Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hi, everybody, and welcome back. Today we have some special guests with us. This is some of the wonderful workers from the Coleman Associates. So I am going to let you guys introduce yourselves so that we have a bit of an idea who you are and what you do, and then we'll get started. Welcome.
Thanks so much for
Thank
having
you.
us.
Yeah, you're welcome. All right, Amanda, do you want to give us an introduction?
Sure. Yeah, my name is Amanda Laramie. I work with Coleman Associates, and I have been with Coleman Associates for 14 years. I started in healthcare I actually started at a not-for-profit in the fundraising side, and then I was a medical assistant, trained cross front and back, and then I was the assistant manager and the manager of my health center before I found Coleman Associates and started doing this work. Yeah, and we can talk about Coleman Associates in a little bit, but that's just my introduction.
Perfect.
Yeah,
Adrienne.
and I'm Adrienne Mann. I'm one of the Coleman Associates also. I'm our Chief Innovation Officer. My background is right after nursing school, I went to my community health center on the south side of Chicago, where I did care coordination, I did clinical education, we did lots of joint commission things and behavioral health integration. I met Coleman Associates when they came to my organization and got really hooked on redesign and making things better for patients who are from communities that are underserved. And I've been here for 10 years now.
Wow, there we go. Okay, so tell us more about Coleman Associates and what they do. Adrienne, do you want to start with what they did in your practice that was so incredible that you wanted to go and work with them?
Yeah. So whenever Coleman Associates came to my practice, and I have to be really clear, we do not poach people because that's really bad for business. But I did a couple of things. So one, I was a leader in the organization at the time, so I got to be part of what the leaders did with Coleman Associates in terms of setting goals. For us, I still remember our goals were cycle times less than 30 minutes, no show rate less than 5%, and getting 100% of charting completion done in real time, which were huge, big, hairy, audacious goals. And especially for me, I was really excited about the opportunity because I am like a lot of nurses where I went to nursing school and I had all of these big ideas about how I was going to change healthcare and provide healthcare on the primary side, which is where I was really interested in. And I got into it and it was just so stinking hard. And I found myself getting burnt out and feeling like I could never serve the patients in the way that I really wanted to, in the way that I had envisioned. And what I learned through my being on my dramatic performance improvement team with Coleman Associates is me and my friends on the site, we redesigned our clinic process from top to bottom so that not only were patients happier, but our staff was happier. We were seeing more patients, and I finally felt like, oh, okay, now I know how you can actually provide care and not hate your life in community health centers. And that made a really big difference for me. And then essentially, I begged Melissa Stratman to take me along a few years afterwards when I had left the organization. And that's how I ended up here.
Got it. So I have some follow-up questions. What is cycle time? So 30-minute cycle time, what does that mean?
Yeah. Sorry. So cycle time is if it's an in-person visit, which at the time we weren't doing as much telehealth as we do now, but it was from the moment the patient walks in the door to the moment that they leave, and it's the number of minutes in between there. And what the reason we look at cycle time is because one, it's a
Hmm.
patient satisfaction measure in terms of a lot of my patients don't have PTO or they don't have easy access to childcare. And so being in and out at the doctor's office is really important to their bottom line. And in addition to that, I think where where we started was, long cycle times mean like, oh my gosh, look at all these amazing services we were providing to people. And what was actually happening whenever Coleman had us go in and do what we call patient visit trackings, where we watch a visit from the beginning to the end, is it was just handoffs, confusion, mishaps that were creating long cycle times. And so what we tend to see is that lower cycle times indicate more organized care, which is better for everybody.
Got it. Okay. All right. Amanda, do you want to fill us in on some other parts of the Coleman?
Yeah, I mean, I think what I just add to Adrienne, and I love that you started with like what Adrienne's story was, because that's how so many of us got hooked on doing this work, is seeing like the transformation happen in person, or seeing, seeing the staff that have better lives afterwards, or seeing the patients have better experiences. Coleman Associates is really great at not only redesigning like how people deliver care, but also developing people in a way that not only helps them professionally through their lives, but really amplifies the role that they have in a clinic or leadership setting. So we do leadership training to help support the kind of changes that happen and transform these health centers or practices we work with. We do some clinician training, but a little different than what you do, but I think it's aligned, where we do like how to be a great clinical leader, how to empower your care team, how to train your care team so that they're more empowered to lead you. One thing, I don't know, Sarah, if you've heard us talk about this before, but because some people are like, whoa, you use this phrase, but Adrienne, I'm going to share like the sheep shepherd model. Like, and we didn't come up with it. A physician came up with it. We were working with, where we're in essence like working to empower the care team around the clinician, specifically usually the MA or the nurse, to be the shepherd of the flow, to be the
Mm-hmm.
person who, you talk a lot about limiting interruptions and making sure the clinician can be in a great headspace to do what only they can do. And we train medical assistants often, and nursing staff, to be the shepherd of their flow so that the provider can operate a little more like the sheep, and not in a derogatory way, but in a like, you're just being shown like where to go next, and we're going to protect you to get your charting done, and then get you into the next exam room and tell you where you need to go and what you need to know behind the door. And so that's some of the concepts of how we transform how people are delivering care.
Got it. Okay. Now, heard you say we're going to reduce no-show times. So I love that, because I was talking with a doctor yesterday who has quite short appointments and a lot of people on her schedule, because the no-show rate is so high that it's going to probably even out, that she'll have a bit longer with patients, which is a really difficult way to practice, because you're really sometimes backed into a corner with all these really short appointments if everybody shows up. It's a big drama. Can you tell us some of the insights that might have helped with improving that no-show rate? What are some of the things that we need to consider when we're thinking about that no-shows?
Yeah. So the way that we think about no-shows are, one is if your no-show rate is higher than 10 or 15%, it's too high, is what I would say. And it matters for a lot of reasons. I come at it from a patient care angle, being a nurse, which is that what I know is that patients that no-show you are usually the people who need to see you the most.
Hmm.
I had the great opportunity whenever I was doing care coordination that Chicago was testing out a system where I could in real time see when my patients showed up in the emergency department or the hospital. And I was doing DPI at the same time, and I would see them no show me in the clinic and pop up in the emergency department. And oftentimes, as I was looking at my utilization reports, it was my folks who were my highest no-showers who were also my people who needed the care the most. And so the way that we think about this is a no-show is a sign of a broken relationship. So for example, if you are planning lunch with your best friend and you can't show up, you're going to let them know, right? You're going to move hell or high water to let them know. Versus if you're like me and you got one of those weird invites from one of your people who you sort of knew in high school on Facebook, you're not gonna let them know, right? And so I start from you need to build a relationship with a patient. I mean, Amanda, do you want to talk about some of the other things we think about in terms of no-shows and how to reduce them?
Yeah, yeah. I mean, sometimes with organizations we start working with, Sarah, we do a mystery shopper call with them to see what it's like to try to get an appointment at the health center. And sometimes we're doing that because we know that sometimes people are like, why don't they just call to cancel? Like, why don't patients just let us know? If they let us know, we could use the appointment for someone else. And when we do those mystery shopper calls and they realize how long someone might be on hold, be like, do you really think someone's going to sit on hold for 6 minutes to tell you they can't make it? They're not. And
Yeah.
so we're preventing, like, we're not making it easy for them to tell us they can't be here. So I think, the ease at which someone says they can't make it is important. We teach processes to frontline staff to help prepare and confirm visits before they come in so that we can gather information from the patient, build the relationship, as Adrienne said, but also like check in with them and say, does this time still work for you? Because you may have booked it 2 months ago and you didn't know what you were doing, March 15th.
Yeah, yeah. And I think that's an important piece of it is this access issue, where if you are going to make your next appointment and the next appointment's in 6 months' time, you're going to forget more likely than if you booked it for tomorrow or booked it for in a week's time. Potentially,
Totally.
like there could be other patient factors, but do we also look at things like access?
Oh yeah. I think so when we start working with organizations, we usually help them set goals, whether we're doing, Adrienne mentioned DPI earlier, which stands for dramatic performance improvement. That's the name of the methodology we use when we're doing transformation. And generally when we start DPI, whether it's like a collaborative engagement or whether it's what we call a rapid DPI engagement where we go on site with a health center and live with them for a week, we always set goals first with the leadership of like, what do you want to accomplish? And then we get actually very more bottom up where we work with the staff to implement the changes, not the leaders. But the leaders help set the goals. And so access is usually always a goal, whether it's how to moderate demand and make sure we're creating more access for patients. And sometimes we're going into practices or community health centers where they don't have enough demand. And so we're working on how to make sure they can fill their schedules. So whether, access can have a lot of different vantage points, but no-show rate is a way to help people improve access. Sometimes we look at productivity and how many patients people are seeing. Sometimes it's just how many patients you're not able to see and wound up as a missed opportunity on the schedule, a chance we could have seen a patient and didn't. And one of the first things is just switching the culture around that. So it's not like the thing a lot of people feel when things are really busy in the clinic, and we usually call that clinical chaos syndrome, is usually people have like a sigh of relief when there's a no-show, of like, phew, like we're able to catch up. And that's totally normal when things are a bit chaotic, but some of it is just shifting to think more like Adrienne was saying of, uh-oh, that person didn't come. I hope they're okay. And how do we make sure we see them and don't burn out our people?
Yeah, yeah. What about role realignment? So I know that when we had this sort of work being done in Canada, one of the things we identified was what each of our staff were doing. And our nurse was in there booking and confirming ultrasound bookings for our patients and booking and confirming x-ray appointments with our patients and really bottleneck of her doing her nurse role, which meant that all the doctors were waiting on patients because they're waiting to see the nurse first. And so we said, what is she doing that for? And we reassigned that to somebody else. Is that some of the things that Coleman's doing?
Go ahead, Adrienne. Do you want to answer that one?
Yeah. Yeah. And I think it's really individualized to each practice because, we see lots of patterns throughout, but each of them looks a little bit unique in each situation. And so what we usually recommend to folks is what I mentioned, that doing a patient visit tracking, which is just watch a patient go through their visit from beginning to end. And you'll see things like that surprise you in terms of like, oh, okay, I see a bottleneck here. And what we tend to think is one is you do want to make sure that folks are doing the right work in terms of thinking about when and where and with who that happens. And what we tend to teach people, and this is why we always start with improving access in terms of reducing no-shows, is we do a lot of work in terms of preparing as well for visits so that, again, you get a shorter cycle time because you're more organized and prepared. And so if we can eliminate some bottlenecks like that, it makes a really big difference. Let me give a really specific example. Is for us in my clinic, what we found was that so we had like where the hall where the pediatricians were at, and we had the hall where the family med folks are at. And anybody who has ever been at a pediatric practice knows that your bottleneck is giving vaccines. And our vaccine refrigerator was in our women's health department, which was a second hallway down, right? And so if you think about just purely how many steps our poor medical assistants were taking to go get all the vaccines for the pediatricians, something simple like that can make a really big difference in people's ability to see patients, right? one of the things that I always encourage folks to do is, especially if you're at an organization that has multiple sites where providers like if you're a clinician and you see patients at multiple different sites, my guess is that even though you are the exact same clinician, your cycle times are different at each site because the literal physical layout, how the team works together makes a huge difference in how those pieces work. Cycle time is never about how fast or slow the clinician is. It's about how well the team works together.
That's so important. I was part of the design. Well, no, we weren't part of the design. We had designed for us this new clinic, and they had room for, I think, 15 to 20 doctors or clinicians working and the front desk staff, and they had two printers in the whole place. So when you printed something, like we would have scripts that were printed, X-ray requisitions that were printed, nothing was electronic at that point. You couldn't send it to somebody's phone. You had to go and get the piece of paper and sign it and then give it to the patient. And you would have to go find, like if we were to have moved into this
Right.
building, had to go find your stuff in amongst everybody else's printed stuff. Can you imagine? I'm like, no,
Yeah.
printer in every room. It's a non-negotiable. Why would we do that?
Right, right. Right, right. And we have these principles of redesign that we've had for a number of years that have since morphed into some more like concrete tactics. But one of them is basically don't be penny wise and pound foolish, like get the tools you need. And when people think like, oh, we're saving money on a hookup for the printer, and it's like, yeah, but how many steps and sneaker time are you paying and all the staff, especially the clinicians running to get that prescription? It's like if you really did the math on that, it's not the best economic decision, but it's a short-sighted thing when you're thinking about the cost of a printer and the hookup.
Yeah, yeah, their thoughts were maintaining printers and keeping paper in the printers, and I'm like, yeah, you have no idea how I work. You could just see the glazed over, like no
Right,
idea my workflow.
right. Yeah, yeah.
So much fun, isn't it? This is so much fun. Okay, now you said charting 100%
Mhm.
complete. Now, and you don't work. This is what I found even more fascinating about that whole piece, because in the primary care networks in Canada, their 2.0 evolution on the video that they brought out to the doctors, it said today's work done today. And I'm like, my ears pricked up because this is before the whole revolution of charting coach, because this was me stuck in my day going, stop adding things to my day. And the
Mm,
video said today's work done today. And I'm like, yes. And I went and read everything. I looked at all their material. I'm like, how am I going to do this? Where are the tools for me? And there was nothing there for the doctors. It was all about working with the team and building the team
mm,
and helping the team help the physicians and the patients in good quality care, but there were no tools for me working in the day. And I'm like, okay, this is interesting because you guys do the same. You don't work directly with the doctors and clinicians, but you have that same desire and goal to have the charting 100% complete. So tell us more, Adrienne, how that happened in your clinic. What the heck?
Yeah. Yeah, I mean, I'll tell you, like when we set that goal as leaders, like our physicians and our clinicians were just like, you got to be out of your freaking mind, right? It's like that's not going to happen. And we focus a lot on the team, and it depends a little bit. Like it does incorporate like some clinician behavior change. I think every clinician I work with has a slightly different style in terms of how they actually do their charting. But what kind of our principle is one is when charting is only the role of the clinician, it's just them, then we get things like an MA getting impatient because the clinician is still charting and they want them to move on to the next patient, right? And it's a totally normal human thing, but if you don't make it is our responsibility to get the clinician home on time, then you have misaligned priorities. And so that's one piece of it. I was working with a really sharp physician who has been a physician for a long time and is the director of the residency program at another organization in Chicago that I just worked with recently. And she has this beautiful way of breaking things down. She's clearly a professor and a teacher, right? And so what she took away from my coaching her on the process was as a medical assistant, our tendency is to teach them to run way ahead of the clinician because the idea is that we're saving time, right? And so if you have ever in your life told or heard an MA told, like, just put them in the room, put them in the room, put them in the room. And we'll see people stack 3 and 4 patients in the room. Or my absolute least favorite is just like bringing them into the vitals room, doing the vitals and sending them back out so that they're like ready for the clinician, right? And what this does is it inherently leaves the clinician in the dust of the MA. And so the way that this, Deb Midgley is her name, I don't think she would mind my mentioning it all because she's phenomenal. What she says is the way she describes it is instead is I as a medical assistant, I get a patient ready. My clinician goes in. I do the handoff with them. They're going into their clinician, and I'm going into their patient visit. And I, as a medical assistant, am going to go slightly ahead of them, and I'm going to go room one other patient. But then instead of continuing and leaving them in my dust, I am going to, after I room that patient, loop back with my clinician, see how they're doing, see if they need anything. Is there anything that I can be doing to get ready for that patient? And once I feel like they have successfully moved on, then I tell them about the next patient. And then again, I go just a little bit in front of them. And then I'm always doing the loop back to make sure that they have what they need. And that it's a it feels like a really simple concept, but it is revolutionary in the way that we think about how clinics flow and how we train medical assistants and nurses. It's honestly one of the hardest things I think we train people to do. Amanda, what would you add?
Well, I mean, when we do the work, Sarah, we always have a clinician on the team. Like when I mentioned that we do this from the frontline staff perspective and, a little more bottom up, like the team of people who are in charge of trying these things out to see if they actually work always includes a clinician on the team. So they are part of it and part of the solution and
Part of the change revolution.
part of it, right? It's not happening I mean,
To them.
to them as they roll out, but like they're part of what these new practices are that Adrienne just described. And it's like we call it the team dance steps, like as these steps. And you have a similar way of like, here's the 4 steps to start getting control of your day. We have team dance steps that are like, here's how you warmly welcome the patient and red carpet them in. And then here's how you do a really robust intake so that you're taking stock in what the patient looks like so you have a good report for the provider. And then the report for the provider is a 30-second report. And then the provider has a chance to think about what they're going to say and go in and hopefully not repeat anything. And, to take your language of what you use as like, what problem are we trying to solve today or whatever it is, to say like, I heard from Adrienne, my MA, who said this was going on. How are we going to help you solve that today? Tell me more about that, and like continue the thread. And then this other step to keep, as Adrienne described, the MA and the provider more in sync versus like one step in front of the other and then not passing and, passing at appropriate times, is this thing we call the Midway knock, which is meant to be a check in with the provider. Is there anything I can get for you? Which sometimes people are doing virtually. Like sometimes they're doing it through a message and not a physical knock. Sometimes it's a physical knock of, hey, Dr. Smith, is there anything I can get for you? And it does 2 things. It gives you a timing signal about like, hey, maybe it's time to start wrapping this up. Maybe it's time to start getting what this patient needs. Maybe it's time to say, hey, Amanda, go get the vaccines going so that you'll be ready to give them as soon as I leave the room. And it just means they're coming to you versus what we've seen a lot as a pattern of people working together is sometimes a clinician comes out of the room and they're like looking for someone to help them and someone's not right there. And then they maybe hand off to someone else and there's a handoff and there's like, I didn't know this patient, and all these things that lead to delays in cycle time or handoffs, which can, maybe mean something gets missed.
Mm-hmm. Got it. Okay. So it doesn't have to be a literal knock. It can be individualized for the space and for the preferences of the team, but it is a lot more coordinated and considered.
Yes.
Yeah.
Yes. And then at the end, I think the piece I missed is at the end, it's either like a baton pass of like, hey, Emma, I need you to get these things done. So the provider can then focus on the charting or focus on what they need to do. And then sometimes we coach MAs to like bodyguard the clinician when they are getting interruptions to be like, nope, she's charting, like give them to me, or she's in there. Please, tell me, I'll find the spot to ask her that, but she's in the middle of her charting before she moves to the next patient. Because we're, our providers tend to, after we train them, we try not to let them get like more than 2 charts behind, if even that, because it's so much harder to get your head back into the patient a few patients ago and finish that up, as I'm sure you spend a lot more time talking to clinicians about.
Yeah. Yeah. So I've seen a recent trend where employers are telling the doctors and the clinicians, no, you're not allowed to spend time charting between patients. And I'm like, wow, we really got that message wrong. Like that, clearly that employer has no idea the mental load and the cognitive slowdown that happens as we start to accumulate things for later.
Mm-hmm. Right.
Yeah.
Yeah. And Adrienne, I don't know if you want to add, but the one thing I want to say is this is where it's not like a one size fits all. Like sometimes people are, charting more in the room with the patient is better. And sometimes it's like, no, I can't do that. I have to do it after, but I want to do it before I go in the next room. Like that's where we're not, it has to be a certain way. I don't know, Adrienne, what you would add to that.
Yeah, I think we think of it as an 80-20 rule of like 80% of the time you want to do it, maybe 90% of the time you want to do it right before you move on to the next patient, or at the very least you want to get in like your main part, right? If there's something you have to go look up or somebody you have to call, like that could potentially wait until later. But I mean, also just like as a nurse, I get nervous about like quality and patient safety if we keep all the charting until the end, not to mention the clinician's mental load. You just
Mhm.
are never going to get charting that's as good if you don't do it in the moment. And I think it's hard. It it's hard because what I find is some of the folks who struggle with it the most are the ones who want like the perfect chart. And what I remind them of is, it's actually significantly worse if you do it later than if you do it in the moment, right? Is you're gonna forget stuff because like I can barely remember what I had for lunch today, and it's just not how our human brains are designed to be.
Yeah, yeah. All right. Tell us about things you're seeing in regards to the messaging and the work lists that are happening, because there's been a lot of change in the last 5 years around this, like patient direct to physician kind of MyChart, for instance, or other types of work lists or emails. Is there any things that you guys have started to put in place for your team trainings around that sort of thing?
Yeah, starting to a lot more just because of the amount of times we go in and people are like, can you just look at our work lists, our inboxes and see what's going on? And the amount of times we like go to multiple people's inboxes or in baskets and we're like, I saw that there and I saw that there and I saw that there. And it's like there's three of them or they're, in multiple people's places. And so I'm sure Adrienne will add to this more, but some of the work we're doing is around like oversight of that, like how managers on the floor can be more involved in looking at what's in there and making sure it gets routed to the right place and not, the wrong thing isn't ending up in someone's inbox who really shouldn't be handling that. Some of it is on the optimization side for sure of like, why is this going to this person, and then in this inbox? Like that's not where it belongs. Adrienne, what would you add?
Yeah, there are two examples that come to mind, Amanda. Is one, I think it was about maybe 5 or 6 years ago that I was on a project with Amanda up in Western New York. And they set a goal, which I love because I didn't know how to hit it. And I love a challenge, which was not only did they want to get to 100% charting completion, but they wanted to get to net zero inbox at the end of the day.
Mhm.
And what we did in that case, and I was like, I love it. I love a time where I'm like, I'm not 100% sure I can do this. Let's give it a shot. Is we built on the same structure where their medical assistant, and I think in this case they had LPNs because New York State rules are strange, but the nurses were looking through their inbox and highlighting things that were really important. And whenever they finished their chart, they were saying, actually, I would like you to take 5 minutes and I want you to do this task now before you move on to the next patient. And I thought that was really effective. The other thing that really sticks out to my mind is another different part of New York, and this was probably like 8 years ago or something like that, where they put me in the call center, which is always a good time. And what I would find is that patients who were calling us, they had had an appointment that day and they were calling because they had questions about that existing appointment or because a medication hadn't gone through or something like that. And so we implemented two things, which was one is we worked really hard on charting completion in real time because that way, like the medication was sent, the referral was sent. So whenever patients got to their pharmacy, that stuff was there. But we also worked on what we called a red carpet exit, where we had the medical assistant walk out with the patient, and before they left said, is there any, like, do you have any other questions that I can answer for you? And what we saw is not only did the number of calls go down, but that the number of tasks in the clinician's inbox went down because we were able to take care of those things in real time.
Got it. Okay, I love that. I have the same audacious goal for the people working within my sphere that their charting is done after every patient and their inbox is zero. And it's like when people hear that, they're like, that's impossible. It's not going to happen. And I, of course, work from the physician side and we spread it out towards the team. You work at the team and spread it towards the physician. So this is why it's such a interesting space to talk to you guys about how this all goes down. So much fun, isn't it? When we're like, how is that going to happen? That's impossible, especially with the continual increase in ask. But I love those examples of how you were able to identify where is those things coming from and how can we cut them off before they begin. So good. All right, tell us about the individual within the team that's being changed. So we've got an organization that needs to consider some change. They've got some audacious big goals. But then we have individual factors. So we have to think about there's disabilities for some of our clinicians, for our MAs, LPNs. So it could be physical, it could be neurodiversity. It looks at all shapes and sizes. How do we start to consider the individuals within these changes?
You want me to take this one, Amanda?
Yeah, sure.
I I think what's really important, and this is definitely one of our principles in terms of how we think about these things, is the best people to determine what changes should be tested and tried are the folks who are doing the work, right? Is if I try and make change in an organization by saying like, okay, I'm going to look at the pyramid hierarchy of an organization, the way an organization chart works, and I'm expecting all the good ideas to come from the very tippy top of the pyramid, it's just not how math works, right? Is most of your good ideas are going to come from folks on the front lines. And so what we try and do, and I think that this gets to the question about like finding solutions that work for the real people, right? Is we share what some best practices are, but I see folks totally make things their own on the front lines in a way that works really well for them, that works really well for their patients, that works really well for them as unique individuals. And I think when you can not only engage people in those problems, but give them the power to make changes in a way that are going to really help their patients, they fly with it. And if I were going to say some like very specific examples is like I had a clinician who was neurodivergent and we did the thing that you mentioned yesterday, which is she needed noise canceling headphones to do her charts. And that is a very cheap solution compared to how much time she was spending outside of work. And you can do things like make sure that, I mean, honestly, it works for folks with any sort of physical disability, but also works just in general for patients. Is like we try and make sure that rooms that you're using are close to where you're sitting and your medical assistant is sitting close to you because that way you
Yep.
have less sneaker time, right? And so it turns out that those solutions that work well for patients often also work really well for the team members.
Yeah.
Yeah. Yeah, I think another example I'd add to that is like someone who they were building a new space and they had a pretty big team room so that MA provider and then sometimes the nurse could sit together, but it got loud. They also had 3 exam rooms per team. So it was like they made one of the exam rooms like where the provider would chart in between patients. And that didn't work the same way for the other clinicians, but that worked best for their team. And that gave them the space to like get their charts done by having privacy and in a room, but it was the exam room.
Yeah, I agree. So this is that part of that innovation of how do we use our space as well, which is really good. Now you said the ideas of how do we prepare for this patient coming in, not the physician or clinician doing pre-charting, but you were talking more about the team is now ready for the day's work
Mm-hmm.
ahead of
Mm-hmm.
time. How does that kind of look when you've rolled that out into different environments? How has that looked for that team preparing for the day?
Yeah, I mean, so again, I think every place does it a little differently. Like some places, the providers work 4 10s or 4 days a week or something, and on the day they're not working, the MA or nurse might do the prep for the following week or something. Sometimes it's happening in the day, like if we've prepped for that day and we've eliminated the things that tend to make us run around and look for things like hospital discharge summaries and notes and the things that we have to grab that take a lot of our time. When the day is prepped for, we often coach on how to work in prep for tomorrow today, because we're working more proactively versus reactively. And the point of the medical assistant doing the bulk of that prep of like looking ahead and saying, last time you wanted to do this and the patient is due for this, and we called them and the patient says they actually have this going on, and yes, they need their meds refilled, and like putting those notes in the system is all so that in the morning huddle, the MA is the shepherd or leading that discussion, so that then the clinician is shepherded or directed a little more to go into the chart and then add the pieces they see and that they see different from their perspective. But the MA is guiding that ship more, and the prep helps them be more, I don't know, more confident too in being that leader because they've done that preparation. I don't know, Adrienne, if you add to that, but that's generally how we see it.
Yeah, I would say what we're often teaching people that kind of blows their minds is like we're not asking the clinician to do all the prep, right?
Mhm.
And I am never going to tell a clinician that you can't look at your charts in advance. Like if you do what you feel like you need to do to be good, but your knowing what's going on with the patients is not the point. The point is for the team to know what's going on with the patients because you only have one brain and having two to three brains looking at the patients is going to make for better care.
And I think this comes back to roles because how do you know the patient's coming back from a hospital visit? How do we know that they have a discharge summary to go find? How do we know if they had imaging since the last visit? We could ask them when they arrive, but that's not going to help us get those things ahead of time. So when they book that appointment, there's going to be conversation happening. And how do we tell our staff how to ask those questions so that we can be prepared for you when you arrive? It makes it a totally different experience from the patient's point of view than why you're coming, right?
Yeah, totally. And I think sometimes the answer we get from people when they first start is, oh, well, they're not going to tell me as the MA. Like
Mm.
they, and that happens sometimes is they're like, I'm not going to tell you about the symptom I'm having. I want to talk to my doctor. I want to talk to my provider. And one of the things we also coach is in order to build that relationship so that patients feel more comfortable telling the support staff as well what's going on is, hey, clinician, the more you boost the role of this person and put your stock into them and say, they're my right hand and whatever you tell them gets to me, and, that they'll be more comfortable telling them. So we have that information in advance to plan for versus have it be the last minute thing that leaves us like kind of running around and taking excess time and time away from charting and all the other things we want to get done. But if we're always being reactive, it's harder to just be proactive and get that stuff prepared for in advance.
Yeah.
And I would just say really specifically, we teach frontline staff, either the medical assistant or the front desk, to call patients in advance and ask questions like, have you been to the specialist or the hospital or the emergency department since we saw you last, right? And then if so, where did you go? And do you need any forms or notes for this visit? Do you have any other, like trying to get all the concerns out as much as you can because it is very different for a clinician to go in to chart for a visit if they knew from the morning huddle that, hey, this person is a hospital follow-up. I already put the hospital follow-up notes in there. So if you want to review them in advance, you can. And just so you know, last time you said you wanted to check in on the labs and you already put those orders in, right? Like that is a totally different visit than finding out when you go in there with what are you here for that, oh, I was just in the hospital.
Exactly. Yeah, that's so important. Speak to me about the tick boxes required for some of the Medicare pieces. So sometimes funding's attached to it, there's bonuses attached to it there's different things that are, more about this than me, but there's priorities each year for a lot of teams. Is that, because I would suggest that is not physician work, not clinician work, that is
Totally
teamwork.
agree. Totally agree. And
I
we've seen
agree.
some places do really cool things with this. One place I coached in Southern California, they started calling it the new patient or annual wellness exam, like concierge service, where they took
Ooh.
a nurse who scheduled appointments with those patients the day before so that the patient was expecting the call or expecting this person. Sometimes they do it in person, sometimes it was over the phone. And they would do a lot of those checkbox things of like asking all the questions that needed to be asked, prior to that patient coming in to see the physician or the clinician, so that it was a better visit for them. And it was like maximize the face-to-face time versus asking all these questions. So we've seen places do that, because one thing we often coach, which can put up resistance on the provider's behalf, is we try to, from access, when visits are different lengths, access is harder for patients, because you know that those longer visit lengths are harder to find and they're really coveted. So when we come in and say, hey, make all visits the same length, one of the first resistance like things to that is, how are you going to fit an annual wellness exam in 20 minutes? Like that, no way. And we're like, yeah, no way, the way you're doing it now, but don't have the clinician doing that part.
Yeah. Got it. Okay. Yeah. So important. Adrienne, anything to add on that one?
No, I think Amanda nailed it. I totally agree.
Now, the electronic medical record can be the limiting factor here, because sometimes it depends on who has access and what level of access they have to be able to tick those boxes on the physician's behalf. So that's one of the objections I've had about this. I like this ahead of time piece, because that way, if the HbA1c hasn't been done, or they haven't had a diabetic foot check for 12 months and it needs to be done, we know that that's the priorities for this visit this time. Super powerful.
Yeah. And I think those are things that often come up when we're doing this work. And again, why the team is interdisciplinary, who's like coming up with this. And we even have an infrastructure team too, which is a little like, they might be in more positions to pull levers, as we say. Like they might have a little more authority to say, yes, we can change the EMR to allow access for nurses for the new patient concierge. Like they're an important piece of this, because often those limitations come up and we're like, well, we've done this in the United States, like in every state, and we know it's possible. So when we push from the end of, we know it's possible, you're not asking the right question, like how can we get the EMR to do this? That has some leverage in terms of someone pushing the envelope on, we can change how this is set up and optimized to work for the team.
Yeah. Another thing that slows down a lot of physicians and clinicians is the way things are put into the EMR. So, for instance, one thing that would drive me completely bananas about my last EMR is if somebody asked me when my last colonoscopy was, and I would have to go digging for that information. And so I had to figure out how to put that information in a way that I could at least find it, because the way it was being done wasn't in a way that I could easily find the answer to that question, which would just drive me bananas. So tell us more about optimization, things that we could consider as part of the ideas for optimizing the team.
I'm pointing to Adrienne on this one just because she's the chief innovation officer and loves the technology side of this, but it, each EMR is a little different. So Adrienne, how would you start answering that?
I'm so sorry. My dog snuck in. So can you restate the question one more time? I do want to answer it.
No, it's the optimization of the EMR. So if I'm having to dig for information like when the last colonoscopy was, that is not cool, because sometimes things come in saying referral letter, or like it isn't listed in a way that I can easily search for and find the information, which slows you right down in the room.
Yeah, so a couple of things about that. One is I do think like you have to have an interdisciplinary team working on how things get filed. It's something I hear all the time in terms of like, well, medical records put it here, and it's just like, well, did you know that, like, does medical records know that that's the easiest way to do it? That, and I think we do a lot of work in terms of it's usually not the clinician who should be digging for the colonoscopy, I guess is what I would say, is one piece of it also in terms of, for example, I'm going to mute for just a
second. Sure. That's her dog.
Sorry,
Oh,
I'm
sure.
her favorite human, and so she cannot be apart from me. So, so I think that that's one piece of it, right? But if I'm thinking about a referral, like one of the things that I would put in my visit prep if I was a medical assistant is I would know that at the last visit that my provider ordered a colonoscopy for that person. And so whenever I schedule the next visit, when I'm with that patient, is I would put a note in there for myself saying, look for the colonoscopy. And I would have that ready to go for my clinician. right? And I think that's another piece about it. And I think like what you were talking about yesterday of just having like the cues in terms of where to look for things is really important. And there are some EHRs that do it better than others, and I think that part is legit, but I think really being thoughtful about how you file things and not just like putting them in a random folder and being like, hopefully we'll figure this out later is it's part of being proactive.
Yeah. So it's not just the physician's job. We really need to start thinking. So the problem is we get stuck in our day and we just work the way it's always done, or we just keep going with how it's always been done. And the ability to pause and take this really detailed examination of how do you work and why do you work in that way and why do we put it into the computer that way and can we get it back out again if we put it in that way and whose job is it anyway? And these are such great places to help us innovate how the clinical day experience goes for our patients and for everybody else.
Yeah, I think the thing that really hooked me on dramatic performance improvement is like you have to be kind of like a toddler and just ask why all the time, right? Is like, why do we do it that way? And do we have to, right? Is we often say whenever we're teaching folks is like the only thing you can't change are load-bearing walls. And even that, with a little planning, maybe you could, right? And so it's just we set up systems to get exactly the results that they get. And so let's just reset up the systems.
Yeah. And we look at everything from like, what is the patient paperwork they're filling out and how many times are we asking for address on it and how long does it take to fill out and does anyone look at it? Does anyone look at it? I coached one team who was like, you know what? Clinician was like, I never look at it because I ask my own questions when they come in. And so we piloted with them, like not filling it out and what would happen, So it's everything that they experience. And, there tend to be things that bubble up as like the low-lying fruit or the highest priority things that are going to deliver the most dramatic results. But, everything is on the table when you do dramatic performance improvement.
Agree. Yeah. Soul sisters.
Yeah.
Everything's
I think we're really aligned.
Everything's negotiable. Totally. Question everything. Really start to notice what's going on. Really start asking why we're doing it that way. Why do I do it this way? What else could I be doing? Is that we have infinite choice and infinite possibilities. I love that. Everything except the load-bearing walls, and even then,
I can be talked into.
Yeah. And Sarah, I like that you used the language I picked on that you used yesterday in the webinar we saw was, be curious. I like that language of like, be curious of what really stuck with me of like, why do I do this thing after I see the patient versus finish the chart? Like, what am I called to do? And looking at that differently. I liked your language, be curious.
Yeah. Is there anything we didn't talk about that we should talk about before we end? And how do people find you?
Yeah, I don't think so. I mean, I think the big thing, like what I appreciate about your work, Sarah, is like the steps, right? Like you're breaking things down into steps of limiting interruptions or how do we approach the visit differently? I think we have similar steps around how do you engineer communication between patient and then care team, like MA or nurse and provider. And that engineered communication, when done with a series of expected steps, can really make a difference in how someone experiences their day. And so that's a lot of what we focus on when we're coaching others. Yeah. And in terms of how to find us, Coleman Associates.org or .com or Coleman.care. We recently got the .care, which is a new URL, but it's an easier way instead of spelling associates, Coleman.care.
And you work in the US and some Canada, is that right?
To be clear, we're open to working anywhere.
Yeah, we're open to working in Australia.
Want to get some flights over here?
Yeah, we would love to. Currently, it's all over the US, but we're open to anywhere. We know healthcare has improvement to be made. Like there's improvement to be made everywhere where healthcare is delivered, and that's what we're interested in doing.
Yeah, love that. All right. Well, thank you so much for this conversation, ladies. Hopefully we have really opened people's eyes to the possibility of things can be different than they are right now. And it doesn't have to be you. It could be us. It's an us problem.
Yeah. Thanks so much for having us. We really appreciate being here.
Yes, thank you.
All right, everyone. Have a great rest of the week.
Bye.
Thank you, Sarah. Bye.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.